Before we go cancer by cancer, let's build the toolkit, because almost every treatment plan you'll ever hear about is a combination of the same handful of tools. There are essentially 7, and the art of oncology is choosing which ones, in which order, for which patient. Let's walk through them, and the 2 questions that decide how they're used. The first 2 tools are local, they treat one specific spot. Surgery physically removes the tumor, and for many solid cancers caught early, it's still the single best shot at a cure. If you can cut it all out before it spreads, you may be done. Radiation therapy is the second local tool, precisely aimed beams of high-energy radiation that damage the DNA of cancer cells in one targeted area. It's used to shrink a tumor, to destroy one that can't be safely removed, or to mop up stray cells after surgery. Both are powerful, but both only treat what they can reach. For cancer that has spread, you need tools that travel through the whole body. The next 4 tools are systemic, medicines that travel through the bloodstream to reach cancer anywhere in the body. Chemotherapy is the classic one, drugs that kill fast-dividing cells. It's broad and genuinely effective, but because it hits every fast-growing cell, including hair, gut lining, and blood cells, it causes the side effects everyone associates with cancer treatment. Targeted therapy is more surgical, drugs designed to jam one specific molecular flaw that's driving a particular cancer, while largely sparing normal cells. Immunotherapy takes a completely different angle. Instead of attacking the cancer directly, it unleashes the patient's own immune system to do it. And hormone therapy starves cancers that run on hormones, like many breast and prostate cancers, by cutting off their fuel. We'll spend whole episodes on these. The 7th tool is more specialized, the stem cell, or bone marrow, transplant. For certain blood cancers, doctors deliberately use very high doses of chemotherapy or radiation to wipe out the diseased bone marrow entirely, and then rescue the patient by infusing healthy blood-forming stem cells, either the patient's own, collected earlier, or a donor's. Those cells migrate to the marrow and rebuild a healthy blood system. It's one of the most intense treatments in all of medicine, with real risks, but for some patients it's curative where nothing else is. So how do oncologists actually choose? 2 questions frame almost every plan. First, is the goal curative or palliative? Curative treatment aims to eliminate the cancer entirely. Palliative treatment, and this is not the same as giving up, aims to control the cancer and preserve quality of life when a cure isn't realistic, and it can add good years. Second, what's the timing around surgery? Treatment given before surgery, to shrink a tumor and make it removable, is called neoadjuvant. Treatment given after surgery, to kill any microscopic cells left behind and lower the chance of return, is called adjuvant. Almost every real-world plan is some combination of these tools, sequenced by those 2 questions. The single most important thing to take away is that modern cancer care almost never relies on one tool alone. A single patient's plan might combine surgery to remove the main tumor, chemotherapy to catch what spread, radiation to secure the original site, and then years of hormone therapy to keep it from coming back. That's why a cancer team includes surgeons, radiation specialists, and medical oncologists all at once. From here, the series goes cancer by cancer, breast, lung, prostate, and the rest, and you'll see these same 7 tools combined in different ways each time. As always, this is educational, not medical advice.